All right, Shayla, should I get going now?
That would be great. Thank you.
All right. Well, welcome to our webinar. We are very excited to be here. My name is Jessie Donato, and I am a hospitalist at the Cleveland Clinic. I'm also an associate program director and the GME liaison in safety, quality, and experience. And I'm joined today by my colleague, Dr. Megan McGurby, who is also one of the associate program directors in our internal medicine residency program. And we are going to be talking about where safety meets clinical reasoning and creating an educational experience for diagnostic safety event reviews. We're excited to have all of you. So after today's session, we hope you will have the knowledge and skills to utilize the DEAR taxonomy and safer diagnosis tool to review a diagnostic safety event. Also identify effective cases for diagnostic safety reviews in medical education, and to have the skills to build an educational experience for your learners to review diagnostic safety events incorporating both cognitive and systems factors. So this will be the structure of our session today. We're going to go through a brief didactic about introduction to this topic, definitions, how to apply these concepts, and then we'll be spending some time in a breakout room to get some activities done, and then we'll do a large group debrief and some closing. So hopefully these will be definitions that you are all familiar with. So medical errors are those unintended acts, which may be omission or commissions, or one that does not achieve its intended outcome. Medical errors may cause harm or may not cause harm, and there are also situations in which harm will occur to a patient which does not involve a medical error. We often think of two different types of medical errors, which are adverse events where harm occurs to the patient, and near misses, which are the accidents waiting to happen in which there are no harm. Our new definitions for today are diagnostic errors and diagnostic safety events. So when we talk about diagnostic errors, we're talking about the failure to establish an accurate and timely explanation of a patient's health problems or communicate that explanation to the patient. When we talk about a diagnostic safety event, we're talking about delayed, wrong, or misdiagnoses in which there is one or more missed opportunity to pursue or identify an accurate and timely diagnosis based on the information available. This may also include situations in which there is an accurate diagnosis available, but this is not communicated to a patient, and this would also be considered a diagnostic safety event. In terms of talking about diagnostic safety, this is something that is incredibly common. Diagnostic errors often involve missed opportunities related to various aspects within the diagnostic process, which may be recognition of key signs, symptoms, and tests. And these are some of the most common causes of patient harm. 1 in 20 patients will experience a diagnostic error in the outpatient setting annually. There are approximately 250,000 harmful diagnostic errors every year in US hospitals, and probably multifold this in terms of non-harmful diagnostic errors. And among malpractice claims, diagnostic errors appear to be the most common, most costly, and most dangerous medical mistakes. So when we think about diagnostic errors, we want to think about what is the underlying etiology. And this is really the foundation of where this educational experience for us came from, that the majority of diagnostic errors have both systems and cognitive components. So we'd love to hear a little bit from all of you and get a little interaction. And this, we hope, will go through the chat. So if each of you can put into the chat whether or not you are currently tackling any aspect of diagnostic safety or diagnostic errors within your program. If you're not yet doing this, what are the barriers and challenges that we might be able to help address today? And if you are doing this, what are some of your successes and opportunities? So go ahead and enter this into the chat. Megan will be taking a look at this, and then we'll try to address this when we get to our large group discussion later in the session. All right. So thinking about some of our challenges in general within medical education of discussing diagnostic errors. There are studies that have shown that clinicians in general are less comfortable in terms of discussing errors in M&M conferences rather than if it was done so in a private setting. They're also significantly less comfortable talking about diagnostic errors specifically when compared to other medical errors. And the reason for this is often that it's considered to be very sharp-ended, and we take a lot of pride in our clinical reasoning skills. And when these are pointed out as faulty, that may be more uncomfortable. Many factors also shape the clinical reasoning process, which are often subconscious. Clinicians report fear about job security and litigation related to diagnostic errors. And in order to discuss these openly, you have to have a really strong culture of psychological safety. So this brings us to the two instruments that we'd like to be introducing you to today, and these are from the HRQ. First, we have the DEAR taxonomy, and this is a tool that helps you to look at each step in the care of a patient to assess where in the diagnostic process an error may have occurred. And the safer diagnostic instrument is a second tool that actually uses numerical scoring for case review to determine the presence or absence of a missed opportunity to make a correct and timely diagnosis. So here's what these look like. So first is the DEAR taxonomy, and this will be available to you today, that basically walks you through all the way from patient presentation and access to care all the way through the follow-up. So this tool is really great. You go through it one by one, looking at each opportunity within the case as you're reviewing a diagnostic safety event to see where were the opportunities. And then on the other side, we have a safer diagnostic instrument, which is actually a quantitative tool. Again, going all the way from presentation and history, all the way through kind of follow-up diagnosis and management to say numerically, where do we think the biggest opportunities are? And then a higher score being a score that would show you there was a lot of opportunity within the case. We find the quantitative nature of this tool can be helpful in two ways. If you have high concordance in the scores, that would show a mutual understanding of the opportunities in the case. And we've also found that highly discordant scores can also be a great opportunity to trigger discussion. So what would we actually do with these tools and with all of these definitions? So what we found is, and recommend that is, in an educational conference, you can provide a case to your learners that involves a diagnostic safety event. And then the exercise in small groups would center around the use of these instruments to complete the case review. We recommend using the DEAR taxonomy first, and then the safer diagnostic instrument, and careful case selection is also extremely important in this educational experience. In terms of thinking about cases in general, these are the general categories that you would want to think about. Delays in diagnosis, which may be either inpatient or outpatient. You can also take multiple approaches to this when you're thinking about patients, for example, as an outpatient with access to care, cognitive biases, atypical presentations, rare diagnoses, navigating diagnostic uncertainty, or the potential of fragmented care or care discontinuity as it results to delays in diagnosis. Misdiagnosis is another consideration, as well as failure to diagnose. This may involve underweighting of symptoms or providing reassurance without workup. And failure to communicate a diagnosis to a patient, as I mentioned in the definition of a diagnostic safety event. So this could be involving a patient, for example, that was non-adherent to testing and treatment because of failure for that patient to understand their diagnosis because of lack of communication. So that was our quick overview. We really want to show you how we apply this. And so in order to do this, I'm going to present a case that involves a diagnostic safety event, and then how you would use these instruments before we jump into our breakout rooms. So this is a case of a 69-year-old gentleman who presents with right hand redness, pain, and swelling for the last 5 days. He reports that the pain and swelling initially started in his right thumb. He went to see his PCP and he was told that it was arthritis, and he was advised to take Aleve and Voltaren topically, along with ice and heat. The pain and swelling continued to worsen, along with development of redness, which spread along the dorsum of his hand. After 24 hours, his whole hand was red and swollen. He continued to take Aleve, but did not have any relief. So he returned to his PCP on the day of presentation and was referred to the ER for admission. He denies any trauma to the hand, including cuts or insect bites. He reports that movement of his hand makes the pain worse, and the pain is intense, stabbing, and an 8 out of 10 in severity. His medical history is as you see here. He has a history of CAD, hypertension, prediabetes. He's had a prior carpal tunnel surgery, but that was remote related to this presentation. He has no history of drug use. He's on multiple medication for his various comorbidities, as you see here, and his review systems is otherwise negative, including no fevers or malaise. On physical exam, his vital signs are normal. He's non-toxic, and he's a middle-aged white male with no apparent distress. He has a soft systolic murmur, and there actually was no significant documentation of the exam in the medicine note, but from the orthopedic note, we noted that the right hand had erythema and edema over the dorsum of the right hand and wrist. There was tenderness to palpation over the dorsal hand and wrist with warmth. The ulnar wrist is more tender in the radial wrist. There was no distinct palpable fluid collection. The compartments were soft, unable to make a fist due to pain. He was able to flex and extend his fingers and endorsed pain at the wrist with flexion and extension. This is the exact wording of the exam, so there was no mention specifically about active versus passive range of motion. Pictures were uploaded to the chart, which are as you see here for this patient. So we kind of will cut to the chase for the sake of this learning environment, but the initial workup included an X-ray which showed soft tissue swelling on the dorsal aspect, which was non-specific and no bony abnormalities. The CRP was significantly elevated at 24 with an ESR of 78. So the course of this patient's illness, he was admitted with a working diagnosis of right-hand cellulitis and was put on IV cefazolin. The patient reportedly felt that he was, quote unquote, getting better, but throughout the daily progress notes from the medicine team, there was no documentation of the exam, including no discussion of the range of motion. The orthopedic hand surgery team continued to follow the patient daily. The medicine staff changed on hospital day 4, at which time there was concern about his exam. They consulted infectious disease because of concern of, actually at that time, infective sinusitis, as the patient had significant pain with active range of motion. Ultimately, the patient was taken to the OR in hospital day 7 for a wrist arthrotomy and irrigation. And the diagnostic safety event in this case involved a delayed diagnosis and thus management of a wrist septic arthritis that took 7 days to diagnose. So a classic example here of a delay in diagnosis. And so this is how we use these instruments. We first did the DEER taxonomy, and this was actually our faculty review of this case, starting all the way from basically patient presentation to follow-up. And these highlight the different areas. And the nice thing about this tool is you go through each component, and it's able to help you say if this was cognitive systems or both. And so, for example, if you see, for example, 3A, which is really documentation and doing a physical exam, all the way down to things that may be considered really cognitive, such as 5B and C, which would be premature closure and anchoring. So things like documentation may be more systems focused, but also involve a lot of cognitive components, and others are fully cognitive with heuristics and biases. The next step that we did, and this is how we use the safer diagnosis instrument, which is basically using these quantitative features. So 1 being, we don't think it's a big feature, 6 being it's a significant feature. So as you can see across all of our scoring systems there, we have a lot of 4s to 6s, which show a lot of opportunities. And that's the nice thing about this tool. So you see here a lot of things about documentation and physical exam being a big component, right? Incomplete physical exam in this case led to delay in diagnosis. Lots of copy and pasting were significant components. Whereas, for example, a good history and getting history got a 1 was not a significant component. Missing follow-up, the patient was inpatient. There was no missed follow-up on testing, for example. So that was not a significant component here. And when you sum all the scores, the score in this case was a 60, which is a pretty high score, which shows a lot of opportunity. What we do after the instruments as part of our debrief is we really call out specific clinical reasoning or cognitive factors as well as system factors. So in this case, a lot of premature closure and anchoring as it relates to cellulitis, diagnostic momentum, confirmation bias, and of course, playing the odds, right? Favoring a more benign diagnosis of cellulitis over a more significant diagnosis of septic arthritis. And then the systems factors. As I'm sure you guys can all relate, lots of copy and pasting issues, both for the exam and the clinical reasoning. Poor documentation of a physical exam, especially on behalf of the primary medical team. Team discontinuity, which is a big system factor, which makes it difficult to track worsening of a physical exam finding, such as in the wrist. Limited and variable bedside evaluations and documentation by the surgical consulting staff. So at our institution, the residents do a majority of the consult work. And actually, most septic joint emissions go to the orthopedic service, so it's less familiar to a medicine team and presents an important systems opportunity. We also try to call out systems opportunities that may play into benefit in terms of diagnostic errors as well, which would be the fact that on hospital day 4, the medicine team changed, which led to a fresh set of eyes phenomenon that led to questioning the status quo of cellulitis. So with that, we're going to give a brief introduction to the breakout rooms. And at this point, Dr. McGurvey, Megan will be taking over to explain this. She has had a few technical difficulties, so just gonna, yep, she's back.
I'm here. Thank you so much.
Sorry, the other thing to mention is that because we've got a nice intimate group of about 6 people, I don't know if you necessarily want to go into breakout rooms or not. You might be able to have your discussion here. Totally up to you as the presenters.
Might be nice if there's 6 of us to just kind of chat through together. That's a good group size.
Yes.
Okay, so using the concepts that Jesse discussed, we're going to have you break out or discuss in this small group for about 10 to 15 minutes, where you will create a learning objective related to diagnostic safety. Try to make it relevant to your experience at your home institution based on, your ideas or what's been going on in your local atmosphere. For instance, if you're starting from scratch, you may want to initiate diagnostic error event reviewing, utilizing the cognitive and systems factors. After you create your learning objective, try to craft a case that might work well to illustrate the concepts that you wanted to illustrate. You can think of a case that you've recently seen, or you can create one. You might want to think through which setting might provide the best example or learning experience, whether that be inpatient or outpatient, multiple visits versus day-to-day stay within the hospital, or how you might want to display your case utilizing documentation or discussion of clinical decision making. As an example, we use the following. So our learning objective in our example was to develop effective documentation skills as a clinical reasoning exercise in order to improve patient care and reduce diagnostic errors. So our case is illustrated here on the slide. We use documentation where there were multiple interrelated problems that were grouped together. This stunted the clinical reasoning and resulted in premature closure. As you can see from this example, there's no discussion of differential diagnoses, and one might presume that the abdominal pain was thought to be due to potentially a mechanical blockage, perhaps in the CBD. Although, as you can tell, there's multiple problems that are discussed together. So our goal was to promote documentation excellence to foster diagnostic safety by focusing on both the systems and cognitive factors that were at play. So after you all create a learning objective, think through the case and whatever goals you might have. Try to think about how you might incorporate the tools we discussed, including the DEAR taxonomy and or the safer diagnosis instrument into this experience. So we'll have about 10 to 15 minutes, and I guess we can just talk through together as a large group. Does anyone want to share like where they're at or what learning objective might work well in their home institution?
Sure. This is Diane Levine. I entered a little bit late, another Zoom meeting, but what resonates with me is this grouping of hashtags where, everybody thinks they're posting on Instagram, and some of those important problems don't get identified. So one of my learning objectives would be to recognize that using a systems approach, linking multiple problems doesn't allow for a development of a differential diagnosis for each problem, with the goal of an appropriate differential diagnosis that's not relisting history without coming to a conclusion. Would be my objective, to create a differential diagnosis that's ranked.
Awesome. And is anyone else, I'm glad to hear that's not just a Cleveland Clinic thing, actually, as sad as it is. Does anyone else have any ideas, or where are you at with kind of where you guys are discussing diagnostic error at your institutions? Is this something that's regularly discussed, or is this kind of starting from scratch?
Sorry, let me turn on my camera so you can see me. I think, we've tried to have a conference once a month where we have residents that have been on the night rotations to talk about we call it shedding light on the night. And we basically have them try to look back at their admissions that they've done previously, and then just sort of look and see what happened to those patients. And it's probably my fault because I haven't sort of done a great job of sort of modeling how I want it to happen. They end up just presenting it like any other case, but really the idea would be looking back at the patient you admitted and saying, hey, was I right? Was I not right? What could I have done differently? And they have a really hard time thinking that way. And they think it's got to be a really interesting case or something really unique. And so it can be really anything. It's just the point is to sort of look back and just reflect on what you were thinking. And, the hashtags are sort of endemic here as well. So I think it's a challenge. I think the other challenge we have is I think they see a lot of patients that the non-teaching hospitalists see, and this is sort of the way the non-teaching hospital, there's often not a differential diagnosis. And I think there's a lot of modeling of just, treating the symptoms and not really sort of trying to put it all together.
That makes a lot of sense. Anyone else? Any other ideas for what we might want to put together in this project?
Yeah.
Go ahead, Dan.
Yeah, I'm just trying to wait. People who know me already know I'm a talker, and so I have to pause. So all of our students submit a near miss or an adverse event report using a reporting system that's similar to the AHRQ reporting system or any of the reporting systems. And they have to identify a case and come up with what the error is. Is it a cognitive error? Is it a communication error? And we have published on that, using that as a way for students to recognize and report. But, and I think in the last iteration, I put down something about what kind of error. Was it premature closure? But I don't remember, because that was the last iteration. I haven't looked at it in a bit. But I think that we already have a framework for near miss and adverse events to identify what is the diagnostic reasoning error in cases where that occurred, and that might be helpful. And I also think incorporating this into an M&M where, we're doing fishbone diagrams and all the safety tools, and we talk about it, but I even think incorporating what, sort of case reflections. I love the shed the light on the night, because it sounds fantastic. But I do think if you have a structured template that has them choose from, the best one I saw was the Merck manual. They have like 20 of these, everybody knows the JJM article and so on, but like which cognitive errors played into this would be so helpful. We had a patient with sickle cell who had a low MCV, and that was just listed as part of the sickle cell. But when you back and ask the patient, they're not microcytic. And it was just incorporated, not recognized, because it was all hashtagged together. But the MCV was like 70. She had menorrhagia. So I think having students, having something templated when you have a case review and having them choose will provide data and understanding what are common problems that students make, and then forcing function and having them identify what the problem is.
Diane, I think that's so interesting. And one thing I even wonder is like what we really like about the DEAR taxonomy specifically is it really gives you a structure. And I think people get really, what I see from trainees, they get really, really caught up in data. And like so much of what we cover is like the history and the physical, which like gets so out of the prioritization process. And these tools are just so nice for structuring of like, did you even get a good history? Did you document the history? And so much of this is we use a lot of real documentation to structure that, to say, those are systems components too. And it really creates for a fun learning experience.
I think for the sake of this exercise, maybe let's just use the documentation and create a case on that, maybe.
Sure.
And then how we might like structure a learning, like how we might be able to do shed light on the night, utilizing maybe an example that came up.
Rob, do you have a case that we could use?
I've got a great one, an outpatient case. It's not really sort of an inpatient case. It's an outpatient case, sort of longitudinally over a few months. I'm certainly happy to sort of tell it, but I don't know that fits so well with this one.
Well, I have one if you don't.
Yeah,
So,
go for it. Yeah, go for it.
So, yesterday at 4 a.m, a patient called me with a sore throat and a fever of 102. She's diabetic. Arranged to have her seen in the clinic with a lot of health systems mess, but she got seen at 4 o'clock in the afternoon yesterday. She had swabs for flu, swabs for RSV, and swabs for COVID, and she was sent out. She called again at 4 a.m. this morning and said her throat isn't better and nobody had swabbed her for strep. And she mentioned that she's had strep throat multiple times and this feels like just like strep. So yes, she's my wake-up call.
It's great.
Great
That is-
case for this.
That is a
I think
perfect
so
one.
too.
That is a perfect one. And then, so maybe how we might want to, restructure this, we'll come up with our learning objective here. In this case, what would you think of maybe as a learning objective we might be able to use?
So recognize the differential diagnosis of sore throat.
And then maybe, utilizing some type of structured approach to going through, an initial presentation, or we could review the case kind of going through it too. So that's great.
And this would also be a great one for just, the obvious cognitive biases that are at play, recency bias or availability bias, recency bias. So, just I love trying to get the residents just to think about those things because, these things will get you every time.
I think, Diane, also to think about, like, as you would consider having them go through the Dear taxonomy, is did they just not take a good history? Like, when patients tell you, like, this feels just like, but if you don't ask the right questions, and getting back to the basics to say the structure of your clinic visit, like, you overcame part one, you got the access, which would usually be a huge limiter. I mean, at the Cleveland Clinic, we probably wouldn't get that patient in, maybe with access issues, and like, wow, you overcame that part. She advocated for herself. You get to part two, and is that where the breakdown went? And then they could learn from that of like how to structure their visit all the way through the cognitive components as well, like availability bias.
I think the component was when this patient was dissatisfied, she told me, my sense is that most doctors don't. I mean, I hear so many complaints from friends and family as well as patients. Most doctors don't listen and they don't give the space for the patient to say that. And we teach in our medical schools these OPQRST AAs of the HPI, and one of the A's is what's the patient's attribution. And so if they had asked, what do you think is going on, reflecting on our curriculum, then she might have said, I think I have a strep throat. A lot of us ask, even though we teach open-ended questions, we do yes, no. And I think this recent case bias of everybody, we're seeing a lot of RSVs, we're seeing still a lot of COVID, and now we're starting to see flu. So that's what everybody's thinking. And there was an attending on this case too, of course. So there is a cognitive bias here. I mean, by the time you're doing a triple swab, one more swab is not a big deal. And there's also something about meeting patient expectations. So I think that in this taxonomy, did they give the patient space? So
That's
I'm
a
looking
really
at
good point. I think the other concept that you brought up that I think is interesting is we're able very easily to like kind of be able to reflect and say, wow, we didn't do this, we didn't do that. And sometimes we don't necessarily have names for the different biases. And I know in our conferences, I think just being able to communicate that is really important. And then oftentimes when we want them to reflect through the different cognitive biases, we actually give them a list where they can kind of read through and say, ooh, this one happened here, this one happened here. And in this case, like another thing that you're discussing is the patient, which is a systems component, not allowing the patient, time to address what they wanted in the history, but also that cognitive component, that unpacking principle. They didn't get the full history because there was premature closure. It's from that availability bias. It was already this, it was already that. So I think an important concept is being able to like communicate and discuss these things that might not have names or we might not have names for, and then providing them that resource. Hey, here are some names for these things that might happen. It's not necessarily as important that you know these, but that you know that they happen, and being able to review the event and call some of these out becomes important.
Yeah, I really like the idea of attribution, as Diane had mentioned. I think and also recognizing, to your point, Megan, about the different biases, because there's definitely what it sounds like an anchoring bias that happened based on, which is a form of cognitive bias, right? Which we know. And I think being cognizant of that as providers will definitely help us frame our algorithmic approach. And then the other thing, John, this is sort of like just a sidebar. I also do palliative medicine, and I'm very particular about language. So even words like error, it kind of makes me cringe because it's, and for a lot of it, I mean, certainly, there is a space where you can just really call that out as such. And then for the most part, it's almost like with an error, there is an intention, which and we know that there's, for all of these things that, at least from what I know, is some of these are inadvertent misses or missed opportunities, and or honest oversight, in terms of, because it's hinging on, our anchoring biases and other forms of cognitive biases, and may not necessarily mean an error in and of itself. But I know that's also the taxonomy, that's part of the taxonomy. And I wish it will, and again, this is just sort of like a sidebar, that I wish there was there'll be a time in the future where we're going to stay away from words that are very judgmental, and actually can, in fact, incite more auditing or maybe even litigation, because we're calling it out upon ourselves, something along those lines. But anyway, I just wanted to share that.
No, I think you're touching on a really, really important topic, which is kind of the crux of our difficulty even discussing and normalizing, bias and errors, even because they really require a lot of psychological safety. I mean, that requires a lot to be able to say, like, hey, and like you said, even on the other component, an additional component, litigation, which comes up as well. So a lot of reasons that this wouldn't be an easy thing to discuss, especially when we're talking about, at the end of the day, there was an individual, associated with this. It's much easier to talk about systems. So that is definitely something that we've tried to take into consideration in our conferences. Our clinical reasoning conference really focuses a lot on biases. And so, this conference, we really try to focus on both. And so we're hoping that by normalizing these discussions, a lot of times we'll provide examples that we've actually been the person who had the error or, had the different biases. And so we share, trying to just normalize that, this happens with staff, this happens with all of us. And giving the stats and kind of talking about how, we reach a certain percentage. Nobody is reaching, perfection. But that is an awesome point.
One thing that I've sort of noticed, I think this thing sounds a little strange, but stick with me for a second. Do you remember when you took chemistry in college? Remember they would always tell you to sort of read the lab the night before so you knew what you were doing? I would read the lab the night before, and then I none of it would really sort of make sense until I went into the lab the next day, and then I screwed it up, and I'm like, oh, that's why they said to let the burette cool before you added the acetic acid or whatever it was, so it doesn't shatter. And I feel like this is sort of the same thing. I think, at least with my trainees, they can read through these things and they can understand it cognitively. But I think until it's happened to them, it's really hard for them to really sort of know, like, oh yeah, the availability bias is a real thing, and the premature closure is a real thing. And that's one of the things I struggle with. It's like they get it sort of, but not sort of viscerally.
The thing about that is, my husband used to tell me you can't teach them everything on the first day or at the clerkship prep course or whatever you want to do. And I think you're right. The lift between year 2 or M2 and segment 3, whatever you want to call it, is ginormous, because the number of problems that they have in our M2 courses, they have a problem and they smoke. And then all of a sudden in the clerkship, you talk about this stuff. So I think recognizing this, providing an example of a case, maybe a case, I love the diagnostic humility, and then introducing it to them before they have to do it. Because we wait until they make an error and then we talk to them. Maybe this is the preparation. Maybe it's an online module, I don't know. But I do think this concept of we all have challenges and diagnoses. Here's an example. Here's the cognitive bias. And here's the opportunities. And now as you go through, think about this, and we'll have some case conferences.
A lot of what we're discussing is kind of the basis of how our clinical reasoning conference is structured. And a lot of times another tool that we utilize in that conference is we have a case that they might work through in real time, and then we'll actually have time to reflect on that later. So oftentimes, even though maybe, like you said, it's hard for that to resonate with a resident or a medical student until it happens. It usually happens in real time when you have them go through a case and put down what their thoughts are in the beginning versus where they were at the end. So it kind of forces that. And even if people are getting, the diagnoses right and the differential was dead on, what biases helped you get there? Did you see this in the past? Was this something, that you've already encountered, or were you already thinking cards because the patient was put on the card service? So trying to call out all of the things that kind of shape our thought processes. I think for a lot of what Jesse and I are doing, it's really trying to look at both the systems and the cognitive factors in each of our cases. So we work really hard to try to select cases where that can really be illustrated for each learning objective that we come up with. So
I really, so Megan, just to add to that, I really like, again, so I think, the systemic and structural factors are definitely at play. And I think when we have these types of sessions where we talk about, issues that certainly have affected in terms of, and have led to a significant outcome on a particular situation, I think, the fishbone, the root cause analysis is really important. And part of the bones of that fish would be, obviously different types of factors, right? Whether it's a provider standpoint or team or the institution as a whole or environmental and what have you, or even the higher ups. And I think that, focusing on more of the systemic factors, which, by and large is really the summation of all of these, including provider under, the provider factors under the umbrella of sort of the systemic change, is definitely important to understand, so that future mitigation strategies can be enacted, so that we don't repeat an outcome that was alarming or that was significantly adverse and affected the patient as a whole. The other thought that I was gonna say earlier, because at my institution, we also have this medical events reporting system, which is a repository of where you log in your complex cases and whatnot. But I think it's not only improving the documentation piece, it's also raising awareness, because a lot of the times people are not necessarily even aware about the existence of such program apps, or this repository, a resource that's available online, and also the type of fascinating or complex cases that need to be reported. Even that has a lot of variability, and trying to standardize that, or have some kind of a standardized framework of this case is in fact something that's reportable versus not. And it would be helpful for folks who are using that, but also that individuals should not be penalized for inputting a fascinating case that may not necessarily be fascinating at all. And it becomes a learning experience for everyone as well. Because I think that there's a lot to be drawn out of really the cases that we see.
I love that. And I think anytime you can standardize any type of approach, it's obviously going to help learners and help us too, kind of as a system. I think we'll kind of move on from this breakout because we have time for discussion later, but wanted to talk a little bit about how kind of we've operationalized this kind of concept into our learning experiences at the clinic. So basically, I talked a little bit about how we have a clinical reasoning conference, and we've had a morbidity and mortality conference for quite a while as well. We basically initiated a hybrid conference where clinical reasoning meets morbidity and mortality. So in this highly interactive conference, we use small group case reviews where we focus on both the cognitive and systems factors. Our first conference, we actually focused on diagnostic safety event reviews. So we introduced the concepts as well as the tools that we introduced earlier, the DEAR and the safer diagnosis instruments. Our case was similar to the one we discussed that Jesse presented, but we did modify it for the sake of this webinar. So it actually included 2 diagnostic safety events in the care of 1 patient. There was a delay in the diagnosis of wrist septic arthritis, like we discussed, as well as a delay in the diagnosis of AML. So our small group activity utilized both of the instruments where each small group tackled one or the other delayed diagnoses. Our didactic then focused on utilizing these instruments as well as debriefing on what cognitive and systems factors were at play in the case. For our second conference, we actually focused on diagnostic errors in relation to medical legal education. So we actually co-led this with our institution's lawyer with the goal of discussing the role of clinical reasoning and documentation of such in diagnostic safety events, and then how that is used to determine whether or not a standard of care was met, in addition to vulnerability for medical malpractice. So we used a case in which there was a delay in diagnosis of DLBCL, and this was actually in the outpatient setting over several different months, with a majority of the care being provided actually via MyChart messaging, which was an interesting case. Our small group used the DEAR taxonomy to review the event, and then we discussed whether or not the standard of care was met in this case. So it was interesting to kind of compare and contrast the different groups with one another. Our lawyer provided the majority of the didactic component that covered medical legal terminology and processes, including malpractice, Ohio tort law, standard of care, and pre-suit mediation. For our third conference, we actually referenced a Joint Commission publication that was highlighting healthcare disparities due to diagnostic overshadowing. For those who might not know, diagnostic overshadowing occurs when certain vulnerable populations receive substandard care when any symptoms they experience are wrongfully attributed to other diagnoses they carry. For instance, we used 3 cases. We used a patient with autism who presented with behavioral issues, a patient with obesity who presented with shortness of breath, and a patient with chronic pain and opioid use disorder who presented with back pain. As you can see, each of those kind of chief complaints could have easily been attributed to their original diagnoses, but these were all misdiagnoses in that other differentials were not considered. The small groups then completed a cognitive systems fishbone for each one of the cases, and then we debriefed cognitive systems factors as well as mitigation strategies to address diagnostic overshadowing as a whole. Some of the future learning experiences we hope to create are focus on documentation excellence, as we used in our example, access to care, care fragmentation, and discontinuity, addressing optimizing interprofessional teamwork to reduce diagnostic errors, and then talking about burnout and contributions to diagnostic safety. Kind of our closing or take-home points for the sake of the webinar are diagnostic safety event reviews are valuable educational experiences for learners that include normalizing discussion of diagnostic errors founded in psychological safety, assessment of cognitive systems interplay, and promotion of common terminology. In addition, the DEAR taxonomy and safer diagnosis instruments can provide structure to these learning experiences. Lastly, diagnostic safety education is a wildly adaptable learning experience that can be utilized in many different settings. We've left time now for further discussion. I know we've already kind of dove into a lot of that, but would love to hear what different people are doing and any new ideas that are coming up. Someone in the chat actually asked about the joint session with legal. Any specific questions that you had on that?
Yeah, this is Shala Paharlu from Mount Sinai. So our M&M has changed this year due to a medical legal, process. And we have, and I think Noel Murray is also on from my institution. So we have had to do a major change in what we are doing. And I guess the biggest, process is that we are focusing on process change rather than, and minimizing the issues that went wrong, because of, cognitive, processing or clinical reasoning. And we're very careful that, none of these M&Ms are being used as a support, evidence for future, litigation. So I'm interested to know how you folks, having that session or working with legal, you've been able to come up with some ideas to have these type of, looking at untoward event and making it into a educational, keeping the educational piece going without compromising so much of, legal vulnerability for the institution or for the individuals involved.
Yeah, so we do everything de-identified. We do take real excerpts, but fortunately, like Ohio law is such that everything is still completely protected within these venues. And so, we were able to take excerpts of the real MyChart messages, for example, in that case where there was actually a lot of contention on whether the standard of care was met in that case because of the nature of MyChart messaging without histories and physical exams and documentation of medical decision making. So we were very specific in that case selection, and our lawyers are very supportive of maintaining that protected nature of all of it. Does that kind of get to what you're mentioning in terms of just like, is the information protected in these conferences?
Yes. So some of the things that actually we were told to do in order, I think state laws are different in many, in each state, obviously. But one of the things that we were told is that people who were involved in the case should not even present. Traditionally, we've had people who were a part of the case present that case and say, these things weren't met, that was when the process went wrong, or could have been better. But at this point, we can't have people who have had, remotely have been involved in the case to be the presenter. And we've seen that, it's the case discussions, case presentations are rich, but we don't have that rich discussion that we used to have when people had, were intimately involved with the case and, they were presenting it. So it's changing the dynamic of our M&Ms essentially. And
Yeah.
I'm not sure, I think it sounds like it's much more, you have a, more, I guess, ways of presenting, the case freely than what we're doing now, with our new rules.
Yeah, it's really state dependent. So for example, because we have a Cleveland Clinic, Florida, and even the safety event reporting system is not protected fully in that state. Whereas in Ohio, like we have zero issues with that. And so, yeah, I mean, in our state, we don't have the challenges, I think, of maintaining any protected information from RCAs and these, M&M conferences and otherwise. So yeah, I guess I don't have a lot of way around that. I think, still de-identifying and having people in the audience to have robust discussion. I think we do most of our cases without people directly involved, and we still get a lot of rich discussion and do a lot of the legwork beforehand, hopefully.
I know in our clinical reasoning conference, the case acquisition that we get is not actually through any event reporting. Typically, residents will come forward with, oh, this was really delayed, or wow, this happened at the outside hospital and then they were transferred over here and look what we figured out. So a lot of times I wonder if this might be a way to chip away at that for your institution, is utilizing cases that people are already discussing on wards that really there was no danger to the patient, or it might be lower risk for litigation, but that, the diagnosis was either surprising to the team or something that maybe hadn't initially been discovered, just to talk about the cognitive component, because it's really sad that, unfortunately, this is such a threat to even discuss at the institution.
Do you have the residents presenting their own cases, or do you sort of gather these cases and then sort of say for an uninvolved resident to sort of present it or talk about it?
I utilize a lot of my own cases, and I've found I can use almost every case unless I slam dunk knew what the heck this person came in with from the get-go. So I think once you kind of open your mind to okay, even if this was just delayed a little bit, I can use that case. It really opens up your case acquisition. On the clinical reasoning side, so, Jesse and I have only had 3 conferences so far. So the way that we looked for cases, maybe there wasn't a huge system that we're using currently. I'll tell you for the clinical reasoning conference that we focus on, a lot of times the resident will come forward I had this great case, I had no idea it was going to be this, or it turned out to be this, and they may or may not, depending on their availability, present their own case. If people don't have cases, like I said, I have plenty. Almost every time I work, I'll have a case or 2 at least. And then I talk to other providers. Dr. Donato gives me a lot of cases, for instance. Really anything that we can kind of dive into, and it might have a tricky differential or a broad differential or something that really in real time was missed or not considered.
And Rob, for this hybrid conference, it's completely faculty led. So Megan and I run it, and so we do all of our case acquisition, whereas our M&M and our clinical reasoning are resident presented. So it's a slight difference in how we structure. So we're super deliberate in our case our case selection for this.
Yeah, it's good. Again, I feel like sometimes the residents they just can't see, like you said, the opening your mind part to it, and say, hey, this is you don't even realize that there was a delay or that there was a cognitive bias at play here. Thanks.
And that's been really helpful. So this case of the AML septic arthritis was my case, it was my patient. And so, in the debrief, it was just this amazing opportunity to stand and be like, hey guys, how many of you guys think you would have missed it? And only half the room raised their hand. And then I was like, yeah, I missed it. I'm your staff. And these things happen, and where can we do better next time?
I'm curious to hear from everyone in terms of what you guys are doing in your respective institutions, because I know when we present these fascinating cases in M&Ms and other types of sessions, there's definitely, it's great to talk about them, but then also, do we have metrics that we're tracking to see the impact of improvement or change that we're aiming towards? So I don't know if other institutions are able to, to do that. At least at our institution, we've incorporated some lessons learned and next steps or action plan. But even at our institution, we're not necessarily great at what are the metrics that what we're doing in terms of M&M and what we're taking away and incorporating changes are actually happening and mitigating outcomes that we were concerned about as we're presenting them. So I don't know if you guys want to share any thoughts.
Dan, it looked like you had your hand up.
Yeah. 2 things. The first one is Nirvani Gulsaran. She was in New York at, I think it was Long Island. And she published about an M&M, and it was a really cool thing. They looked at the problems that were identified, and they came up with a quality improvement project after every M&M. This was resident based, and it was very structured. And so they came out with improvements in their system, and she was loved by her institution. She just left to run a quality improvement program at another hospital. But it's Nirvani Gulsaran, and she has really some great publications. And one of the other metrics that if you think we're preparing our students to become residents is reporting. And so we were able to demonstrate that students increased their reporting from 6%, which is, there's only one other article, to 18%. We know that most reports come from nursing. We know that reporting is contentious, but we were proud of that. And the last thing that might be incentivization is that you can report near miss or adverse events to the Agency for Healthcare Research's M&M, de-identified, and students will get $300. It is the same format as our assignment. And we've had several students, and there is a way for them to put it on their CV. They can say that they submitted a case that was accepted. They cannot discuss the details because that's the requirement. But if they wish, they can supply the letter of acceptance so that it can at least go on their CV. And there's only about 180 cases on the M&M so far. So it's still pretty cool.
One other thing that we do with this conference is we actually collect all of the instruments as artifacts to track how the residents are doing. And that's been our mechanism also for scholarship from this work. But it's a very intriguing process to review. So like the tier taxonomy, for example, in conference 1 and conference 2, and looking for both concordance and discordance in like the numerical ratings on safer diagnosis, because Megan and I always do the tools ourselves for each case as well. And so I think that's a way you could track, right? Over time, are you getting greater concordance on the safer diagnosis instrument? And so these are just like cool things. This is how the tool became validated as well in the initial publication. So those are really benefits of these instruments.
Great, thank you. Oh, Diane, can you drop the name of Nirvani? I think that.
Yeah, sure.
I know in our conference too, mostly what I've measured so far is just like resident perceptions on how this is made implications on their practice. And so we've had very kind of positive ratings that they believe that this has probably shaped kind of their clinical practice. Unclear if it has or not. I don't have great outcomes on that, but just in evaluating kind of the curriculum.
We just have a few minutes left. Does anybody have any other questions or comments?
I really appreciate this opportunity to just share brilliant minds ideas with all of you. I know we attempted to do the exercise, and I don't know if we came up with the actual intention of, but there was just a lot to learn from this activity, and just a space to be able to share thoughts and ideas with colleagues is really great. So thank you.
We appreciate your input so much. This was awesome because of you guys. So thank you.